Good morning, everybody. I'd like to welcome you all. Thanks for coming. First of all, I'd like to welcome our friends, colleagues, and delegates from different countries in Africa to join us in the annual event of the Egyptian Society of Cardiology, which is the Cardiology Updates 2024, the best of ESC, which will cover the new ESC guidelines, atrial fibrillation, chronic coronary syndrome, peripheral arterial disease, the different guidelines, hypertension as well, in addition to the new clinical trials, which will have an impact on the practice of cardiovascular diseases management in the daily clinical practice. We will have the opening ceremony for this event after this session. So I'm very happy that we have different professors from different institutions in Cairo and every part in the country to join us as usual in the annual event of Cardiology Updates. So without further delay, I'd like to give the stage for the chairman of the first session on atrial fibrillation, Professor Mirvat Abou-Almaati, Professor of Cardiology at Ain Shams University, Professor Mohammed Oussama, Professor of Cardiology and the past Director of National Heart Institute, my dear friend, Professor Touré from Niger. So they will chair the first session on atrial fibrillation. The floor is yours. You can start by introducing the session.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. Welcome to our African friends from French-speaking countries. And I would like to thank Dr. Magdi Abdelhamid for his tremendous effort to bring us together and also to bring the latest news from the European Society of Cardiology to our continent, Africa. And I'm thrilled to be chairing this session, Dr. Mohammed Oussama and Dr. Ali from Niger. And we'll start with an eminent speaker from Cairo University, Dr. Emmanuel Faris, who is going to give us a question or answer a question, what's new in the 2024 atrial fibrillation guidelines? Dr. Emmanuel.
Good morning. Thank you for inviting me to this elegant meeting. The first topic is what's new in the 2024 ESC atrial fibrillation guidelines that were released in the last Congress in August in London. Why atrial fibrillation? Because atrial fibrillation is a distressing disease for the patient. It can produce many symptoms. Patients have palpitations, they get shortness of breath, they have fatigue, chest pain, dizziness. They suffer from a poor exercise capacity. With recurrent episodes, they can get anxiety, depressed mood with disordered sleep. Atrial fibrillation is associated with poor adverse outcomes. Patients have recurrent hospitalizations. They can develop heart failure. The most feared complication is ischemic stroke due to thromboembolism. It has been recently associated with development of cognitive decline and vascular dementia and depression. It is associated with an increased risk of death. Atrial fibrillation has an impact on the healthcare and society because it's a prevalent disease. The lifetime risk is 1 in 5 individuals will develop atrial fibrillation, and this is expected to increase to 1 in 3 individuals with the aging population and improvement of the healthcare. And it's an expensive disease, and the cost of AF management is about 1 to 2% of healthcare expenditure in European countries. The first major change in the guidelines is a change from the ABC pathway to the integrated AF care pathway. The two pathways share similar points. There is addition of 1 point and reordering of other points. CARE stands for C for comorbidity and risk factor management, A to avoid stroke and thromboembolism, or to reduce symptoms by rate and rhythm control for evaluation and dynamic reassessment. That's the central illustration of the AF care pathway, and we will go through some of these points. We'll start with the C, comorbidity and risk factor management. This is the initial step in the management of all patients with atrial fibrillation, regardless of the type of atrial fibrillation. And it is central for successful management because it will reduce the recurrence and progression of AF. It will improve the success of AF treatments, including ablation, and will prevent AF-related adverse outcome. The guidelines specified 6 comorbidities that are important. They are hypertension, diabetes, heart failure, overweight and obesity, the exercise capacity, and alcohol intake. And these are the targets for the management of comorbidities. For hypertension, we are aiming for a target heart rate that is below 130 systolic and 80 for the diastolic blood pressure, or as low as can reasonably be achieved. For heart failure, starting the GDMT, especially diuretics to alleviate congestion, SGLT2 for all degrees of ejection fraction. For diabetes, the use of medications and diet. Medications, they emphasized on the use of metformin and SGLT2 inhibitors. For obesity, a weight loss program for patients who are overweight or obese, with an aim to lose 10% or more of the body weight. For physical activity, a tailored exercise program for regular activity, and that's around 150 minutes of moderate exercise per week, or 75 minutes of vigorous exercise every week. For alcohol intake, it is advised to reduce the alcohol consumption to 3 or less standard drinks per week. For sleep apnea, they have a class 2B recommendation for the management of obstructive sleep apnea, and a class 3 not to depend on questionnaires alone for diagnosis of obstructive sleep apnea. The second pillar for the management of AF patients in the care pathway is A, to avoid stroke and thromboembolism, because atrial fibrillation increases the risk of stroke 5-fold. The risk is not homogeneous and depends on the presence of specific risk factors, and that's the second major change in the guidelines, because they updated the definition of the SHADS-VA score. Now they removed the female gender as a risk factor for stroke, and it's now the SHADS-VA instead of the SHADS-VA score. How to deal with this? You will have to start oral anticoagulation in eligible patients. That's a class 1 recommendation, and the type of AF, whether it is paroxysmal, persistent, or permanent, it does not have any impact on your decision to start or withhold anticoagulation. And the important thing is that antiplatelets do not offer protection from thromboembolism. We use the SHADS-VA score for patients who have a score of 2 or more. That's a class 1 recommendation to start oral anticoagulants. For those who have a SHADS-VA of 1, it's a class 2A. In some patients, you have to start oral anticoagulation regardless of the score, and these include patients with hypertrophic cardiomyopathy or cardiac amyloidosis. Which anticoagulants to use? The guidelines advise the use of DOAC, except in patients with mechanical valves or mitral stenosis. If we are using a vitamin K antagonist like warfarin, the target INR is between 2 and 3, with more than 70% of the time in the INR range. If we cannot do that, then it is advisable to switch to direct oral anticoagulant. Safety is important, so we have to assess the bleeding risk and manage all the modifiable risk factors for bleeding, but we should not use the risk score to withhold anticoagulation. Again, platelets are not advised to protect solely against stroke, and you cannot combine a platelet with a direct oral anticoagulant for stroke prevention, and it is not advisable to continue a platelet with an oral anticoagulant in patients more than 12 months in patients who have chronic coronary syndrome or peripheral vascular disease to prevent bleeding. The R, that's where most of the work is done here, because that's where you get many choices and you have a lot of shared decision making between you and the patient. R is to reduce the symptoms by rate and rhythm control, and it is essential to improve the patient quality of life because you reduce the symptoms, and in some particular cases it can improve mortality and prolong the patient's life. And they created 4 pathways for first diagnosed atrial fibrillation, paroxysmal atrial fibrillation, persistent and permanent atrial fibrillation. And we have many choices. The rate control drugs, cardioversion, antiarrhythmic medications, catheter ablation, endoscopic and hybrid ablation, surgical ablation, or ablatant pace. These are the options that are available for all the patients. When you decide to cardiovert a patient who has atrial fibrillation, the first thing that you have to put in mind is safety for the patient. So the number 1 question would be the hemodynamic stability, because if the patient is hemodynamically unstable, you will have to go for emergency cardioversion. If not, we have to check the oral anticoagulant status. If he's in oral anticoagulant for a minimum of 3 weeks, we can go for cardioversion or a wait and see if he will cardiovert spontaneously within 48 hours. If he's not on oral anticoagulant, then we'll have to check the duration of the atrial fibrillation. If it is less than 24 and we are sure that it is less than 24 hours, we can go for cardioversion. Otherwise, the guidelines advise that the patient should undergo a transesophageal echo. And that's a change from the previous guidelines where the threshold was 48 hours. Now it is only 24 hours. The patient pathways, they cover the major aspects of AF care, and they are based on the time-oriented classification of atrial fibrillation. Patients who have a first diagnosed atrial fibrillation, we'll check the hemodynamic stability, and we have to start with the 2 first pillars, the C for comorbidity and A to avoid risk of thromboembolism. And in these patients, the first step would be to initiate a rate control with medications depending on the ejection fraction. If it is low, we have beta blockers and digoxin. If it is normal, we can have beta blocker, digoxin, or non-dihydropyridines, calcium channel blockers, or a combination of these drugs. And at last, we have 2 options, either to cardiovert the patients medically or by DC cardioversion, or we wait up to 48 hours to see if the patient spontaneously returns to sinus rhythm. In paroxysmal atrial fibrillation, again, the first step is the C and A, and then a rate control strategy, and that's an important step in all the pathways. And then the patient, we have to include the patient in making the decision for the next step, because we have many options. We have medications, antiarrhythmic medications to maintain the sinus rhythm, or we can go for a catheter ablation as a first line, and that's a class 1 indication in paroxysmal atrial fibrillation, and also it's a class 1 if the medical treatment failed to maintain sinus rhythm. Patients with persistent atrial fibrillation, that's a more complex situation because we meet these patients while they are in atrial fibrillation. So again, the first step would be the C and A, and then a rate control depending on the ejection fraction and the shared decision making. Sometimes we have to consider to do an electrical cardioversion to see if the patient will return to sinus rhythm, to assess the symptoms of the patient to see if the symptoms will improve after cardioversion or not. And the main difference between persistent and paroxysmal atrial fibrillation is the role of a catheter ablation as a first-line therapy. In persistent atrial fibrillation, it's a class 2B. Unless the medications failed to maintain sinus rhythm, then it becomes a class 1. In patients with permanent atrial fibrillation, again, at first we have to do the C and A, and then it's a rate control strategy for everybody, using the medications depending on the ejection fraction. The target heart rate is less than 110. Unless the patient remains symptomatic, then a more strict control is required. In some patients, the ablation provides a survival benefit, not only improvement of symptoms, and this includes patients with AF and HFrEF who have tachycardia-induced cardiomyopathy, or patients with HFrEF to reduce hospitalization and prolong survival. New in the guidelines, the use of surgical or endoscopic or hybrid ablation. Surgical ablation of atrial fibrillation is indicated as a class 1 indication in patients who will undergo a mitral valve surgery, and the class 2A in patients who will undergo non-mitral valve surgery. The E stands for evaluation and dynamic reassessment. In patients who have atrial fibrillation, you have to reschedule a meeting 6 months after presentation, and then at least annually or based on the clinical needs. And during these visits, you will have to assess new or existing risk factors and comorbidities. You have to revise the shared VAS score. You have to assess the risk of bleeding and assess the symptoms if they change after therapy or not. So the key messages, the guidelines document recommend treatment using the AF care pathway. A joint decision-making regarding the best option for AF management should be made between the patient and the provider. Comorbidities should be evaluated to avoid and managed to avoid recurrence and progression of AF, improve success of AF treatment, and prevent AF-related adverse outcomes. Assessment of the risk of thromboembolism is used using the CHEDS VAS score. Rate control can be used as initial therapy or adjunct therapy to rhythm control or as a sole strategy for treatment. Rhythm control should be considered in all suitable AF patients, and the patient should be periodically reassessed to identify new risk factors or improve the quality of life and prevent adverse outcomes. And thank you very much.
Thank you, Dr. Emmanuel, for your presentation, a nice presentation. So I think that it's better to continue all the presentations together because it is the same topic on atrial fibrillation, and then after we do the discussion. I think it's much better. So we move to the next presentation, which will be done by Dr. El-Damati. We have known him since yesterday with his famous case. So he is presenting on atrial fibrillation, rhythm versus rate control, which is the C of care in the atrial fibrillation new management. Dr. El-Damati, you have the floor now. Thank you.
Sabah al-khair, good morning, bonjour. It's my pleasure to welcome you again to Cairo, and I would like to thank the panel, Professor Abdelhamid, for giving me the honor of presenting this topic. And I've been given the eternal question of rate control versus rhythm control in atrial fibrillation. And these are the items that I would address in this talk. So I'll start off with the rate versus rhythm control dogma, and then we will see how this dogma was challenged recently in the general population, how it was challenged in patients with recent atrial fibrillation, how it was challenged in patients with heart failure, and what's practically what we do in rate control and rhythm control in every day life practice. So the rhythm control versus rate control dogma cannot be mentioned without mentioning the time-honored AFFIRM study. The time-honored AFFIRM study was published in the New England Journal of Medicine. It randomized patients into a rhythm control strategy that was basically antiarrhythmic medications versus rate control. And it looked at the composite endpoint of death, disabling stroke, major bleed, and cardiac arrest. And the results were a little bit disappointing in terms of rhythm control. So it turns out that rhythm control does not give any benefit in terms of this composite endpoint, and the only benefit was felt to be better symptom control. But there has been a lot of limitations regarding the AFFIRM study. So first of all, the AFFIRM used medications, and we all know the risks of antiarrhythmic drugs and how they can be deleterious. Rhythm was only maintained in about 60% of patients, so perhaps only 40% achieved the target. And unfortunately, these drugs were neither effective nor safe. So recent data challenged this dogma in the general population. And one study that has to be mentioned in this context is the Cabana study. So the Cabana study tested a pure rhythm control strategy, which is atrial fibrillation ablation, against a hybrid approach that used medications for rhythm control as well as rate control medications. So it was not purely a rhythm versus rate control study, but it was a catheter ablation study versus medications. It randomized over 2,000 patients into these two arms, and it followed patients along for about 48 months. And one more time, the results were disappointing in terms of the composite endpoint of death, disabling stroke, serious bleeding, or cardiac arrest. So again, we're faced with the fact that rhythm control in the general AF population only offers symptom relief, but there is no survival benefit or major adverse cardiac events benefit. But looking into particular patient population, so patients who have recent atrial fibrillation was looked at in this important study, the East AF Net 4 trial, that looked at patients who have less than 1 year history of atrial fibrillation. But they were high-risk patients, so their Schatz-Vasquez score was high, they were elderly, they had previous TIAs or strokes, and they had lots of comorbidities. When these patients were looked at in terms of an early rhythm control strategy versus the usual care, which was basically rate control, and the investigators looked at the composite endpoint of cardiovascular death, stroke, or hospitalization with heart failure or acute coronary syndrome, the results were, in this study, really promising in terms of the rhythm control strategy. So the cumulative incidence of this composite endpoint was lower in patients who had early rhythm control. And that was the first category of patients where we have a hard cardiac endpoint in favor of rhythm control. And the investigators of this study concluded that in patients who have early atrial fibrillation and concomitant cardiovascular conditions, there was a lower risk of death from cardiovascular causes or stroke or hospitalization because of heart failure or ACS. So really good hard endpoint achieved with rhythm control. In this recently published Garfield AF study, which is an observation study that looked at about, or even more than 45,000 patients, and these were, it's an observational studies, but they were prospectively looked at, and looking at the rhythm versus rate control in this prospective cohort, all the endpoints that they looked at, namely the all-cause mortality, the non-hemorrhagic stroke, and the major bleeds were in favor of the rhythm control strategy. So another large study, not randomized, yet large study that proves the benefit for rhythm control strategy. And then another important group of patients with heart failure. So this dogma was again challenged in this group of patients. And this was through a very important study that is the Castle AF study. So in the Castle AF study, about 400 patients were randomized to an ablation arm and conventional therapy, which was basically rate control. These were patients with left ventricular ejection fraction that is less than 35%, and all of them had an ICD or a CRTD, so there was a very rigorous way of monitoring their atrial fibrillation. And the investigators looked at the primary endpoint of all-cause mortality and worsening of heart failure. And in this important study, again, the composite endpoint was lower in the arm that had ablation therapy. So another group of patients who would benefit from rhythm control. Another group of patients that actually changed the guidelines into putting patients with heart failure and atrial fibrillation as a class 1 indication for AF ablation. The investigator concluded that in patients with heart failure, there was lower rates of composite endpoint of death from any cause or hospitalization from worsening heart failure. So does this apply to patients who are ambulant and well, they have heart failure, but it is controlled? Is it the only group that would benefit? So the investigator of the CASTLE-HTX study investigated this question. So this is a recently published study where the investigator looked at catheter ablation in patients with atrial fibrillation and heart failure, but end-stage heart failure. So all these patients were waiting transplant, a patient that you would leave alone and give him medical treatment. And surprisingly, when the primary endpoint of composite all-cause mortality and worsening heart failure or requiring urgent transplantation on an LVAD looked at, patients who had atrial fibrillation did better in terms of the primary endpoint, and when death mortality was looked at alone, also patients who had ablation did better. In this recently published meta-analysis that looked at rhythm versus rate control study in major trials, so AF-CHF, AFFIRM, CASTLE-AF, EAST-AF-NET, RAFT, and CASTLE-HTX, the investigator of this meta-analysis concluded that when they looked at all-cause mortality, cardiovascular mortality, and heart failure hospitalization, all the data in these major AF and heart failure studies pointed to a better response in patients who had early rhythm control. So what do we do in real practice in terms of rate control? Rate control best suits a patient who is elderly. He is minimally symptomatic at most. He has recurrent atrial fibrillation. He tried antiarrhythmic before, but it didn't work. And he has perhaps an atrium that is huge, and he is unlikely to maintain rhythm. So what are the options? Medications, the most commonly used option, or a plate and pace strategy. So the medications are basically chosen according to the comorbidities. So you have lots of options. Beta blockers, calcium channel blockers, digoxin, AMU can sometimes be used for rate control, and dronedarone. So which patient would take which drug? So patients with no cardiovascular comorbidities, you can choose whatever you wish. Beta blockers, calcium channel blockers. Patients with hypertension are best treated with a drug that would treat both, so beta blockers or calcium channel blockers. If the patient has heart failure, you cannot use calcium channel blocker. You're only left with beta blockers or digoxin. And if the patient has COPD, you can use beta blockers or digoxin or verapamil. Amiodarone has to be your last option. You cannot use amiodarone from the get-go. It's only left for patients who are resistant. So what rate should we target? According to this study, the RACE2 study, where the investigators looked at this composite endpoint, they found that lenient rate control is as good as strict rate control. I'm gonna go quickly for the sake of time. Option of ablate and pace is always useful, but you have to make sure that your patient achieve close to 100% biventricular pacing so that he would benefit from the ablate and pace strategy. So rhythm control, either antiarrhythmic drugs or catheter ablation, it's suitable for patients who has a first episode, or patients who are highly symptomatic, patients who gets heart failure that is precipitated by the atrial fibrillation, and young patients to avoid the long-term effect of antiarrhythmic drugs. So this is the algorithm that we follow. If we do not have structural heart disease, the options are wide open. Unfortunately, if we have structural heart disease, there are certain important classes of medications that you cannot use, namely class 1C antiarrhythmic drugs. What's the role of catheter ablation? Catheter ablation has been upgraded in the latest guidelines to a class 1 indication in patients who develop heart failure, and it used to be in the guidelines before the 2024 a class 2A indication if it's the patient choice. The real change that happened in these guidelines is that it's now upgraded to class 1 indication if the patient agrees that he would need a procedure done. So these are my take-home messages. In the general population, the proven benefit of rhythm control over rate control remains to be just better symptom control. We do not have hard evidence that proves that there is a major cardiac adverse events reduction if you adopt a rhythm control strategy. Yet, there is growing evidence that praises the role of rhythm control strategies in patients with heart failure and in patients early in the course of their disease, less than 1 year. And finally, therapy should be tailored for each individual patient according to the age, the preference, the comorbidities, and most importantly, symptomatology. And with that, I conclude. Thank you so much.
Thank you, Dr. Ahmed. Illustrative, elegant as usual. According to our rule, we will postpone discussions till the end of the session. And now I have a pleasure to introduce my dear friend, dear colleague, Dr. Mohammed Al-Maghawri, consultant of cardiology, National Heart Institute and in NAS Hospital. Dr. Mohammed will shed the light on the what can we do, ablate or medicate AF in heart failure patients.
Thank you, Professor Mohammed. I'm his student, of course. I'm not a colleague. I'm much honored to be a student of many of our professors here. Bonjour à tous. Je dois parler en anglais parce que this session is in English, but bienvenue au Caire. So the initial talk was AF ablation versus medication. I kind of changed this title to AF ablation in heart failure patients because, as we know, medications is a cornerstone in the treatment of in the management of heart failure patients. So I think the question is, when should we offer a patient the AF ablation? So I will start with a case. This is actually a real-life case that I have seen 4 months ago. He's a 62-year-old man. He was referred to me not in a NAS hospital, but in a different hospital. He has a history of hypertension over the last 10 years, and he was in and out of atrial fibrillation over the last 3 or 4 years with progressively more difficult atrial fibrillation to be controlled. And he was on and off NOACs, and the patient was not particularly compliant to the medical treatment, and he had a recent echo with ejection fraction of 55%, and then he presented to the ER with rapidly progressive palpitations and early heart failure symptoms with an ejection fraction of 25%, and coronary artery disease was ruled out, so they referred him to the electrophysiologist on call. Before we carry on with the case, we'll just look at the literature, and we'll just review what is offered in the literature and what is offered in the recent guidelines. So AF and heart failure has always been going hand in hand for a very long time. And since 1997, Eugene Ronwald, in a landmark lecture, he predicted that the paradigms in heart failure in the next century, in the 21st century, would be heart failure and AF. And quite rightly, the shift in the healthcare system and expenditures in treating heart failure and AF has significantly increased over the last 10 to 15 years and expected to even double or triple over the next decade. So we know that AF begets heart failure and vice versa. That's from a 2016 study looking at the Framingham heart failure cohort, and about 30% of patients with heart failure will get AF, and about 30% of AF patients will get heart failure. And there's so many reasons for this, but simply if you're hypertensive, you're a smoker, if you have diabetes, you will get both. You will have high risk of heart failure and you will get high risk of AF. If you have AF, you can have tachycardia-induced cardiomyopathy. If you have tachycardia-induced cardiomyopathy, for whichever reason, you may get AF. So there's a lot of interplay. Similarly, in HFpEF patients, if you are overweight, if you have uncontrolled diabetes, if you're a smoker, if you have depression, if you have obstructive sleep apnea, you will have AF, and you may also have HFpEF. And this will lead to atrial electrical and mechanical remodeling, which will lead to eventually increased pulmonary venous pressure, which will change the sympathetic activation and into an endless loop of AF and heart failure. So I think Professor Damati has answered all the questions related to ablation in AF, so I will make my presentation much easier and actually much more difficult because I'm not as elegant as Dr. Damati in presenting. But we know from the Cabana study that the initial outcomes of the Cabana study, which was looking at the effect of catheter ablation versus antiarrhythmic drug therapy in AF patients, were quite shockingly negative in the sense that both arms showed the similar results, whether you give the patients drug therapy or catheter ablation. The endpoint, the primary endpoint of death and disabling stroke, serious bleeding, and cardiac arrest were quite similar. However, if we dig deeper in the Cabana study and we look at the crossover arms, there was about 15% that crossed over from the drug therapy to the ablation, and about 10% from the ablation arm that did not receive ablation. And that kind of really changed and diluted the effect of the ablation. And if we look at this study where we take away the intention to treat and we put the per protocol analysis, there is definite benefit from the catheter ablation for the composite endpoint, either after 6 months or after 12 months. Similarly, and that actually goes earlier, from earlier studies on small number of patients, on the management of persistent AF and heart failure patients, over and over we see that the catheter ablation showed better results than medication alone. And that's from the Harefield group back in 2013 with the VO2 max improvement after 6 months. And also related to BNP values improvement. Similarly, from another British group, the CAM-TAF trial, that's in 2014, showing similar results. However, these were small number of patients. We had a larger study, which is the ATTACK multi-center randomized study, which from the Italian and Andrea Natali groups, and that was published in 2016, that had a randomization of about 200 patients, and the endpoint was stronger, meaning that they were looking at a number of hospitalization and death, and again, patients who underwent AF ablation had a better outcome than patients who had medical therapy alone. That was again shown in an MRI-based study, which is the CAMERA study, and that was published in 2017 with significant improvement in the ejection fraction looked at by MRI after ablation in heart failure patients in comparison to patients who were kept on medical therapy alone. Similarly, the long-term outcomes of the CAMERA study showed similar results after 4 years of follow-up. And then came the landslide study, which was mentioned by Professor Damati, which is the CASTLE-AF, which significantly showed important and reproducible results of that the ablation fares much better than medical therapy alone in patients with heart failure in terms of hard endpoints as death and repeated hospitalization. However, these results were not reproduced with the AMICA trial, which is an important trial, multi-center, randomized from the Cox Group and Gerard Hendricks, who are eminent electrophysiologists in Germany. And they showed that the results were not, there were no significant improvement in AF ablation arm versus the medication arm. However, when they looked at the reason for this was that the follow-up was not long enough to show the results. So the CASTLE-AF results were significant after 1 year, and the real benefit showed after 3 years because of, at that time, the atrial remodeling would reverse the ventricular remodeling. However, in the AMICA trial, it was only looked at 1 year follow-up. So the results were a little bit diffuse for this reason, and they are now looking at the same results after 5 years follow-up. Again, as mentioned by Professor Damati, CASTLE heart failure study for advanced heart failure, which is CASTLE HTX, showed significant improvement in very advanced heart failure patients who were enrolled for heart transplantation or LVAD procedure. So what are the guidelines say regarding management of AF and heart failure? As mentioned by Dr. Emmanuel, we have now a different approach, which is a more patient at the heart of the care, and it's a multidisciplinary approach with the CARE points that really need to, every physician need to look at. So if you look at the R, and we look at the patients with paroxysmal AF with heart failure, catheter ablation actually comes as a class 1 indication, as a first-line therapy. And this is very important. So you can give the medications, or you can offer the patient straight away AF ablation. And if the ablation, if the medications fail, then you really need to offer the patient again the AF ablation. Similarly, in persistent AF, the results, if the medications fail, then you need to offer the patient catheter ablation. However, as a first-line therapy, catheter ablation is a class 2B, and the reason is because we know that the results of the AF ablation in persistent AF are not as solid as with paroxysmal AF. So the earlier you catch the AF and you offer the patient an AF ablation, the better the outcome would be. And we are, with the development of the newer technologies, we now know that the AF is still, of course, a risky procedure. It's a long procedure. It's a very invasive procedure. However, with the newer technologies, the risks are becoming less. So with, for example, the cryoablation is becoming, usually it's a quicker procedure than the radiofrequency. And with the pulse field ablation, it's quicker and with less risk of esophageal or phrenic nerve injury. And with that, I conclude my talk, and I'll just give you a brief follow-up of the patient that we started with. He actually, we tried to do a cardioversion for him, and we couldn't, so we give him amiodarone for 1 week, after which he reverted without cardioversion, and then he couldn't do an MRI. And after 3 months follow-up, he is still on amiodarone, and he's on optimal heart failure and NOACs, and no symptoms, and the patient is back to exercising actually, and his ejection fraction has improved to 60%. and his original cardiologist is referring him back to me. So I would like to ask all of you, what would you do to this patient? Would you keep him on amiodarone and heart failure medications, stop amiodarone and stop his heart failure medications, stop amiodarone and keep his heart failure medications, or stop amiodarone and offer AF ablation and keep his heart failure medications, or do everything, keep amiodarone and offer the AF ablation and keep his heart failure medications? Thank you very much for your attention.
Thank you very much, Dr. Maghaouli, for excellent presentation and explaining how to use rhythm control in subgroup of patients with the heart failure patient. We'll move to the last speaker, Dr. Haitham Badran. Dr. Haitham is the professor of cardiology at Ain Shams University, and he is the president of the Egyptian Cardiac Rhythm Association, and he is one of the eminent and leaders of electrophysiology and SEEDS treatment in Africa and Egypt. Dr. Haitham will speak about post-operative atrial fibrillation. Dr. Haitham.
Thank you, Professor Mervat. Thank you, Professor Magdi, for the invitation. It's my pleasure actually to be here once more. So my talk today is about post-operative atrial fibrillation. So do you think it's matter to talk about only post-operative atrial fibrillation in a specific talk, not atrial fibrillation per se? Actually, it matters, and I will show you why. So at first, do you recognize this man? Do you know this guy? Anybody knows this guy? So this is Ethiopian, the first guy to do an ECG, and this was the first recorded atrial fibrillation ECG. It was in, I think, in 18 something. So this was the first recorded atrial fibrillation ECG, and this was Ethiopian recording the ECG. So why bother ourselves with the post-operative atrial fibrillation? Actually, we have exponential growth of data and of trials in the last decades about the post-operative atrial fibrillation. This is because regardless the type of surgery, whether cardiac or non-cardiac, the post-operative atrial fibrillation was associated with increased hospital stay, increased economic burden, and increase in the major adverse cardiovascular events, and even increasing in mortality in the patient who developed post-operative atrial fibrillation. So what's the definition? It was defined in the latest guidelines from the European Society of Cardiology as it's a new onset of AF immediately after surgery. However, it does not show whether it's requiring treatment or not, because some of the trials was only including post-operative atrial fibrillation requiring treatment or needing treatment, and excluding other patients who didn't need any treatment or who cannot have any treatment regarding the atrial fibrillation. And whether it's for lasting 30 seconds or more than 10 minutes, it was not clear in the guidelines about the duration of post-operative atrial fibrillation, and whether it's any episode or episode after 2 days or 4 days, long episodes, it was not clear about the definition, what is the post-operative atrial fibrillation really means. But about the incidence, it's very common actually after the cardiac surgery, reaching up to 50% after the valve surgery, less of course after CABG, but after the valve surgery it might reach something like 50%. After thoracic surgery, ranging from 15 to 30%, especially after extensive thoracic surgery like the pneumonectomy, for example. For the non-cardiac surgery, it might reach up to 15%, depending on the predisposing factors, of course. So what's the pathophysiology? It's rather complex, depending on something pre-operative, the predisposing risk factor in the patient itself, including age, hypertension, diabetes, presence of some sort of chest problem, and genetic predisposition. This will lead to some mechanical remodeling inside the left atrium, creating a substrate or areas of re-entry, which will act again as a substrate for re-entry after the procedure or after the surgery. And then we have a perioperative pathophysiology or preoperative risk factors, including the surgery itself. For the cardiac surgery, it's the arteriotomy and the cardiopulmonary bypass. This will create some sort of electrical remodeling also inside the atrium. And then later on, post-surgical, the inflammatory process and the autonomic nervous system activation, together with the substrate, it will act as some triggers by changing the criteria of the calcium handling and creating some sort of electrical remodeling. So now we will have a substrate and trigger for triggering atrial fibrillation post-operatively in the predisposed patient, as I mentioned. For the non-cardiac surgery, it's about the predisposing factors together with the stress of the surgery and the presence of non-infection inflammation, or the inflammatory markers increase post-surgery as most of the patient will suffer. So what's the impact? What's so important about the post-operative atrial fibrillation. Actually, besides increasing the hospital stay and the economic burden, the post-operative atrial fibrillation is usually associated with increase in the major adverse cardiovascular event, and this was shown either because this post-operative atrial fibrillation will predispose later on to the non-surgical atrial fibrillation. I mean, the patient who develop post-operative fibrillation carries something like 4 times to 7 times risk to develop atrial fibrillation later on in comparison to the normal population, and will suffer from the same major adverse cardiac events of the atrial fibrillation like stroke and heart failure, and even increased mortality. And this is some data showing that we have something like 7% increase in mortality even after 10 years of the surgical procedure in the patient who developed post-operative atrial fibrillation. And this is also in the non-cardiac surgeries. The patient who developed post-operative atrial fibrillation will have something like 3-fold increase in the stroke, 4-fold increase in myocardial infarction, and 3-fold increase in mortality in comparison to the patient who didn't develop post-operative atrial fibrillation. So how to manage? Like everything, as Benjamin Franklin said, an ounce of prevention is worth a pound in cure. So you have to prevent the atrial fibrillation to occur post-operatively. But you think this is easy? Of course not. So we have different factors to do prevention in atrial fibrillation post-operatively, including well-established medical treatment like the beta blockade, the amiodarone, and we can give some magnesium post-operative overdrive by atrial pacing. So we have multiple options, but every single option of this has some problem or a defect that prevent it from causing the complete prevention of the post-operative atrial fibrillation. So for the beta blockers, it's indicated in the guidelines, in the American guidelines, a class 1 before the cardiac surgery to have beta blockers to prevent the post-operative atrial fibrillation. It is well related with minimal complication, but actually it is a contraindication to give beta blocker in the non-cardiac surgery to prevent post-operative atrial fibrillation. It's class 3. So if the patient is going non-cardiac surgery and is not indicated for beta blockers, you should not give a beta blocker to prevent post-operative atrial fibrillation in non-cardiac surgery. For the amiodarone, it is very effective, studied many times to prevent atrial fibrillation in both cardiac and non-cardiac surgery, but it carries the risk of acute lung injury, which is a severe fatal form of amiodarone toxicity. Hypotension induced by the IV infusion may limit the use of amiodarone in some patients. Sutalol is also as effective as amiodarone in some studies, but yet you have the problem of QT prolongation, cannot be given in patients with heart failure, so sutalol has some limitation. Colchicine was studied and it was promising, but the data is conflicting about whether it can prevent post-operative atrial fibrillation or not. Statins, steroid, and even botulinum toxin were studied even in animal models, and it shows some regression of the post-operative atrial fibrillation, but not very conclusive data. And then we have other more advanced option. We have a mapping guided ablation, which we can do for prevention of atrial fibrillation in highly susceptible patient. We can do mapping and ablation, and even ablation of the ganglionic plexus, prevent the post-operative atrial fibrillation, but usually the surgeons are very reluctant to do so because it is a time-consuming, it's not an easy procedure. Similarly, the atrial overdrive pacing, we have a very strong data about the atrial overdrive pacing, especially by atrial overdrive pacing to prevent post-operative atrial fibrillation, but still the surgeon don't like to do this because it consumes much time, it's demanding. Pericardiotomy, it's a very good option actually, especially if the patient cannot take medication to prevent post-operative atrial fibrillation. The idea about posterior pericardiotomy per se is to create a space where you can drain the blood and the fluids outside the pericardium to the left lung space, decreasing the stress on the left atrium and decreasing inflammation, and hence decreasing the incidence of post-operative atrial fibrillation. And actually, this was stated in the guidelines. This is the most recent guidelines by the definition and by the drugs we are just mentioned. Beta blockers you can give as a class 2A, of course, amiodarone as well, but you should avoid beta blockers in non-cardiac surgery. It's a contraindication. The pericardiotomy also is indicated as a class 2A in some patients when you cannot give drugs and when you expect post-operative atrial fibrillation in such patients. So what about the treatment? So the patient developed already post-operative atrial fibrillation. Shall we go for rate or rhythm control? It's very clear if the patient is hemodynamically unstable, you should go, of course, for direct cardioversion to maintain sinus rhythm and to maintain the stability. But if not, if he's stable and he's asymptomatic, there were multiple trials comparing rate versus rhythm in the patient in the post-operative atrial fibrillation, and it shows it might you might not get any benefit for maintaining sinus rhythm of such patients, although we don't have a long-term follow-up data for these trials, but it's there. But the main problem, usually, of course, for the rate control, you use beta blockers, digoxin. If the patient is heart failure, you can give calcium channel blocker if the patient is not in heart failure or depressed ejection fraction. For the rhythm control, usually they use amiodarone. Sometimes we can use class 1 or class 3 antiarrhythmic drugs, especially if the structural heart, normal structural heart of the patient. For the anticoagulation, this is a big debate, to give anticoagulation or not in such patients. It's not as easy question as you imagine. So we have multiple data, multiple trials, and this meta-analysis comparing anticoagulation versus no anticoagulation in the patients following cardiac surgery and non-cardiac surgery who developed post-operative atrial fibrillation. It shows actually a very marginal benefit in terms of thromboembolic risk reduction, but also it shows increased bleeding, significant increased bleeding, together with sometimes increasing mortality. So if you give long-term anticoagulation in the post-operative atrial fibrillation, regardless of the SHADS-VAS score, you may risk bleeding and increasing mortality without actual benefit. Similarly, the American Thoracic Surgery Association shows this meta-analysis as well. It shows that if you give anticoagulation in the post-operative AF, regardless of the SHADS-VA, you might have increased mortality by 20%, increasing bleeding without significant benefit regarding the stroke. So this is very important, whether to decide to give anticoagulation or not. So what to do in such patients? Actually, the prevention is the first step. If the patient is at high risk, you should optimize the hemodynamics. This is the first step. You should include beta blockers if cardiac surgery, amiodarone in some selected patients, or even sotalol. You can use other antiarrhythmic drugs, of course, to prevent if the patient is at very high risk to develop atrial fibrillation post-operatively. And then during the operation, you can use either in the cardiac surgery, either posterior pericardiotomy or biatrial pacing to overdrive to prevent an instance. And if the patient developed post-operatively and hemodynamically unstable, you should go, of course, directly for electrical cardioversion together with systemic anticoagulation for at least 3 to 5 days. And then for the hemodynamically stable patient, you can either rate or rhythm control depending on the symptom of the patient and how difficult to control with the beta blockers, calcium channel blockers, or digoxin. And then at discharge, you should decide whether the patient will continue for anticoagulation long-term or not. So you have to reassess the patient later on at the follow-up for the decision of anticoagulation. So my take-home message, the post-operative AF is a common potentially fatal complication. Prevention is the key, of course, to prevent the complications. Treatment pathway is challenging and should be individualized according to the patient risk and outcomes. Thank you.
Thank you very much, Dr. Badran. You have understood, I think, since the beginning that this session on ESC recommendations is to welcome you in the jungle, wandering jungle of electrophysiology. And as I can see, everyone has a mineral water and a glass of water in front of him. I think that you bring your Tylenol tablets and the aspirin tablets. And hopefully we have the mom who cook a wonderful muluhia. In case Tylenol or aspirin cannot work, the good muluhia she had cooked will help you not to prevent thromboembolism, but the headache you may have in the jungle of electrophysiology. I think that you have understood that we have this lady, I had to introduce her, is the president of the task force of AFRA, which is the African Heart Rhythm Association in the Pan-African Society of Cardiology. So you discover that mulihia, the good mulihia she cooked, can prevent headaches. Either if you have no aspirin or Tylenol with you. So this is to introduce the president of AFRA, Professor Marwat, well known by the Egyptian, but not by the other African cardiologists who are here in the room. So, je crois que vous avez compris, c'est la présidente de AFRA, la nouvelle présidente de AFRA, Professeur Marwat, qui est la présidente du groupe de troubles du rythme et au niveau de la PASCAR, et qui est la présidente de cette session. Elle va donc ménager. Et comme je vois, je disais que chacun a sa bouteille et son verre. Si vous avez oublié vos comprimés d'aspirine ou de paracétamol, elle fait du bon. Ils ont une sauce qui s'appelle le moulouhiya. Ça peut aider, pas pour la prévention des complications thromboemboliques, mais pour prévenir les maux de tête qu'on peut avoir dans cette jungle d'électrophysiologie. Merci beaucoup. Je vais passer la parole. Maintenant, la discussion est ouverte pour les 4. S'il y a des questions, s'il y a des... yeah. Give him a microphone. Okay. You have to applaud our mom. Yeah. Thank you very much.
First of all, thank you to Professor Magdi for organizing this interesting meeting, and thank you for the speakers for this session that was really informative. I have a question to Damati. Regarding the decision to go for rhythm control or rate control, there are some criteria you showed us. One of these criteria is the size of the left atrium. So which size exactly that makes you to take the decision to go for rate control? Because I saw some patients with left atrial size 4.4 or 4.3 with the age of 50, having atrial fibrillation of less than 2 hours, and the decision was with some cardiologists to go for rate control. And this is, for me, was strange because it's just a mild enlargement of the left atrium. So which size actually makes you to decide, oh, it's better to go for rate control? It's 5, it's 5.5, it's 4.8, whatever.
Thank you, Professor Hassan, for this very important question. It's actually a dilemma that we face every day. So I do not believe there is a fixed number. So if you think that there is a fixed number that I will give you, unfortunately I will not. Because it's rather a continuum than a discrete number that you below you would ablate, above you wouldn't. But in my practice, I usually do not try to do ablation procedures with atria above 55 millimeter anteroposterior diameter. If it is above 6 or 6 or above, I do not touch these patients with ablation procedure. It's a bit different when it comes to cardioversion and antiarrhythmic drugs. Perhaps you can be more liberal with the cardioversion because it's an easy procedure with low risk. So I can sometimes try to cardiovert patients up to 56 or 58. But what I can say is that with small atria, the recurrence rate is much, much less. So obviously I have no restrictions on doing ablations or DC cardioversions in atria that is less than 50 millimeter. And I don't know what's the practice of other electrophysiologists in the room. Professor Maghauri, Professor Badran, Professor Faris.
I would like to ask the floor for any questions. Haitham? Okay. I would like to add that radiofrequency ablation in Egypt and in Africa is an expensive procedure, but we try to make it successful from one session. So we do all our efforts to select the patients, as Ahmed Damati said, and to do the procedure as efficient as we can. Less complication and higher success. Therefore, we can have the trust of a very expensive procedure for such group of patients. The government is providing this service on 2 scales of the insured and the Dawla patients. So this is a good privilege for patients in Egypt. And this is provided in University Hospital and in Insurance Hospital and National Heart Institute and all over Egypt. So we can provide this service, but we cannot provide it to all. We have to select the patient who is going to benefit, and we have to explain to the patient that this procedure is one step, could need another redo or a third one. So the patient has to expect that the success rate in the best hands, Damati, Haytham, Maghauri, is between 75 to 80% for those paroxysmal patients. For the persistent patients, this is another story. Permanent AFib patients, we don't touch. We haven't reached the level of hybrid procedures here in Egypt, not yet. So I think the same in Africa, in Tunisia, and in North and East, West and South Africa. I'm not sure of South Africa. Usama?
I have a question. Actually, they eliminated the 6 from the Schatz-Vask score. Americans, they elaborated their guidelines 6 months before European, and they didn't exclude 6 from the. And this was based on trials actually, or just a view, our general view? This is my question for the speakers.
Emmanuel, do you have an, I have the answer, and this is shocking answer. The shocking answer I heard from one of the interventionists, Shahab al-Atribi, in our last meeting, that because of the gender change and the intersex, and the people don't know if they are a woman or a man, they took it out.
Okay.
Yes.
Yeah.
Based on a
And
trial.
this is shame for science.
Actually, I can accept it on a trial, but without a trial, this is shameful.
Yes, I agree. Yes, it might be the reason, but I mean, they didn't declare that clearly. This is the reason in the latest European Society of Cardiology. They said that when they revised the data from the trials, there was no specific gender difference regarding the outcomes. This was the reason they removed it. But I mean, it could be like this, of course, because of the multiple genders they have. But
The gender,
yes.
the Schatz was introduced 2004.
Yeah.
And upgraded to Schatz-Vask 2020. This based on a trials.
Yes, a single trial actually, and the trial, there was some question about the Schatz-Vask. It's a very strange question, whether the stroke is related to the Schatz-Vask score, related to the atrial fibrillation, or just for the Schatz-Vask score. Because if you imagine a patient with congestive heart failure, hypertension, diabetes, these are the patients who will develop stroke anyways. So do you think atrial fibrillation may increase this or not? This is the question. So it might be the Schatz-Vask itself is the risk profile for the stroke patients, not the atrial fibrillation. So the trial for the Schatz-Vask was something like 2,000 patients. And if you look at the score, you find something very strange. The patients with a very high Schatz-Vask score, like 9, they have less stroke than the patients with Schatz-Vask score like 5. So this is very strange because the sample size was not very big, and actually this type of patients, they might develop stroke without atrial fibrillation. So you just give anticoagulation for protection, of course, but this is not the true answer of the story, because I think the size of the left atrium matters, the shape of the P wave matters, the carotid artery matters, so it's rather complex than the Schatz-Vask.
Also, I have other question. Patients with Schatz-Vask 0, guidelines, whether American or European, both of them ignore this category of patients. And this category of patient is a good number of patients, young patients, having AF and at risk of stroke. Actually, it is low risk, but I think still indicated for anticoagulation, but both American and European guidelines ignored this category of patients. What's your comment?
Like doctor, the risk of stroke is high in patients who have one or more points from the Chad's VASC. In younger patients who do not have any risk factor for stroke, the stroke rate will be very low, and prescribing long-term anticoagulation for these patients will not be beneficial given the bleeding risk.
But actually, if this patient with Chad's VASC score 0 is having atrial fibrillation and you like to revert him to sinus serism, actually you should do TEE. That means the risk is not 0.
Yes, so there are...
and this is conflict inside the guidelines.
Yes, and it's exactly like another conflict. If you have a patient who is on long-term anticoagulation and develops atrial fibrillation, would you still send him for a TE or not? Okay, you will send him. So, what if you find a thrombus in the left atrium? Would you still prescribe 3 weeks of anticoagulation and cardivert him anyway, or redo the TE as well? The new guidelines suggest that it's a class 2A to repeat the TE. So obviously we still have some gray areas that are not yet defined. So maybe in the future, more patients will have anticoagulation.
Okay. Merci beaucoup. Bienvenue à nos invités de pays africains francophones. Nous sommes honorés de vous accueillir dans notre pays et nous nous souhaitions un agréable séjour au Caire en visitant le monument et les musées et souhaitons une collaboration en médecine. Merci à tous et bienvenue.